So, good afternoon, surgeons. I welcome you all on behalf of LabGuru and Medtronic team for this live webinar on GI and HPB surgery. Today's webinar will be conducted by eminent and senior faculty members from Ramakrishna Care Hospital from Raipur, India. They'll be sharing some interesting cases of viewers and their experience on various cases in specialties such as hernia, bariatric, GI, and HPB. So stay tuned. Each speaker, I would like to highlight here, viewers, that each speaker will be talking for about 15 minutes, and followed by which we will be having a question and answer session. So if you have any questions after any of the topics, please do post them on the chat box on LabGuru. We'll be waiting for 2 to 3 minutes after each topic for your questions. If there are no questions, then we'll move on to the next topic. So without wasting much time, now I would like to invite the team of surgeons from Ramakrishna Care Hospital and Dr. Dave sir, who is the medical director at Ramakrishna Care Hospital. Dave sir needs no introduction, so over to you, sir. We can please start.
Thank you. Thanks a lot. And good afternoon, viewers. I'm Dr. Sandeep Dave, Chief Laparoscopic Surgeon at Ramakrishna Care Hospital. And I'll be speaking on behalf of my team, who will be talking more on details regarding hernia and bariatric surgery, which will be delivered by Dr. Tamaskar, hepatobiliary and pancreatic surgery by Dr. Ajit Mishra, and laparoscopic GI surgery by Dr. Vikram Sharma. So this is all what we are going to talk in today's deliberations, which will be more case-based and our experiences too. Our team has performed more than, together we have performed more than 50,000 laparoscopic surgeries in this part of the country, right from simple as well as advanced laparoscopic surgeries. In recent times, we are now venturing into GI and HPB surgeries also, along with our GI surgeon, Dr. Ajit Mishra. So I'll hand over to Dr. Siddharth Tamaskar, who will be speaking on hernia and bariatric surgery. Dr. Tamaskar, please.
So may I please request you to start your web camera also?
Yeah, am I visible now?
Yes, sir. Please go ahead.
Yeah, a very good afternoon to you. So we'll just move ahead with the first talk in our so though this series is related to the GI and hepatobiliary pancreatic surgery, and we would be covering a short what do you call it, a short video on bariatric surgery, where we would also be going through a small video of sleeve gastrectomy. So because these are the common surgeries being done in our place, so we thought we'll start up with a short talk on laparoscopic groin hernia surgery. So I'll just go ahead with the talk, and in the next 10 minutes or roundabout, the talk would cover 3 major aspects of groin hernia. One is the basic anatomy, the laparoscopic view, then what you call it as the 10 steps, and of course we would also go on a few slides on how to choose a patient for a groin hernia surgery for people who are just starting around. So because it's a basic topic, just like to go through certain basic points in this. So the laparoscopic perspective is quite different. Surgeons are used to the anterior approach, and a transformation to the laparoscopic approach requires the knowledge of the posterior approach, posterior technique. So the preperitoneal space is the most important thing what we have to know in laparoscopic groin hernia surgery, and its extension is vital to the laparoscopic surgeon. All posterior approaches have to traverse this area. The other most important point during a groin hernia surgery is to know about the myopectineal orifice of Frouchard. So the overall gist of the surgery is to cover all the potential spaces where you have In 1956, here Henry Fouchard has espoused this theory that all the hernia originates in the small weak area called the myopectoral orifice. So as soon as the scope is introduced, what we can see once we put a scope or a camera towards the inguinal region, we can see the peritoneal landmarks. There are three ligaments: the median, medial, and the lateral. And there are three fossa, which is the supravesical, the medial, and the lateral. So here you can have a small orientation on how you can visualize the things. This is the direct defect that has been labeled with D, because it is lateral to the inferior epigastric vessels, that is the lateral umbilical ligament. We have the median umbilical ligament here. That's this is the continuation. Just below it, you will find the urinary bladder. We have the medial umbilical ligament extending up to, once you pull it down, you can go up to the iliac vessels. Here we have the, like I told you, the lateral umbilical ligament, and here we have the cord structures. So this is how we view it, and the iliopubic tract will traverse through this area here. This is the area where the iliopubic tract will go through, and the iliopubic tract, the anterior to the iliopubic tract will be the direct and the indirect hernia, and the posterior to the iliopubic tract will be the femoral hernia. So here you have a small video. Once we initially enter, there you can see the ligaments. That is the medial umbilical ligament. Here you have here. That's the medial umbilical ligament. And this is a left-sided inguinal hernia. Here you have the lateral umbilical ligament on the left side. And this is an indirect inguinal hernia because the hernial defect is lateral to the lateral umbilical ligament. Here you can again see the same structures on the right side. Those are the vessels. There we will find the iliac vessels. And there you have the cord structures, inferior epigastric vessels. That is the lateral fossa. This is the medial fossa. So that is the view when we see this. Now the next step is, after making incision in the peritoneum, because I am a TAPP surgeon, so I will talking about some more of TAPP. So after the peritoneum is incised, dissected apart, there are four structures which are to be identified. That's the internal ring, iliopubic tract, the Cooper's ligament, and the femoral canal. Now, systematization of laparoscopic inguinal hernia repair. There's been a landmark study by Furtado et al. And it's based on a new anatomical concept, which is called the inverted Y and 5 triangle concept. So we just will go through all these things. The inverted Y is formed by the vessels here, and then all these fossa which will be described. The anatomy is divided into 5 triangle based on this inverted Y. Here you have the direct hernial defect, which is labeled by D. Sorry about that. Here you have the direct hernial defect. This is the indirect hernial defect. This is the triangle of doom. This is the triangle of pain. And this is the area where we have the femoral hernia. So these 5 triangles are important. Now, just a word about the triangle of doom. So it is defined by the ductus deferens medially, testicular vessels laterally, and external iliac vessels inferiorly. And no staples should be placed in this triangle. We don't have to specify this again and again. So here you can see that is the triangle of doom. Here you have the vas. Here you have the spermatic vessels. And here the inferior border is formed by the reflected surface of the peritoneum. Now, it's very important to know about the nerves of the pre-peritoneal space, because these are the structures which you need to preserve, and the injury to these nerves are going to make increase the morbidity of the patient. So the genitofemoral, lateral femoral cutaneous, the femoral, ilioinguinal, and the iliohypogastric nerves. There you have these different nerves which are passing through, and these triangle, like I previously mentioned, is called the triangle of pain. It means it often contain unknown small nerves also, and it may also contain an aberrant ilioinguinal nerve. The very important thing is that no tags or extensive dissection in this area. So that is the triangle of pain. The upper border is the iliopubic tract. Here we have the internal inguinal ring. These are the spermatic vessels, and here you have the reflex. So what the paper describes is barely this area is divided into 3 zones. Here we have labeled it as lateral zone, which is the area 1, central zone, the medial area is the area 2, the central zone is the area 3. So zone 1 is lateral area to the deep inguinal ring and the spermatic vessels here. Zone 2 is medial to the inferior epigastric vessels and vas deferens, which is this area, and corresponds to the side of this area, which corresponds to the side of the direct hernia. Zone 3 includes the inferior epigastric vessels and deep inguinal ring superiorly and spermatic cord and external iliac vessels. So let us have a small view on what is an ideal candidate for a laparoscopic inguinal hernia procedure, because we know that not all hernias are the same. So an ideal candidate for beginners who want to start in laparoscopic hernia is basically a primary unilateral or a bilateral hernia with no history of previous lower abdominal surgery, or the patient has had a history of open repair, inguinal hernia in females, and sometimes in few patients where you can combine it with lap chole or the routine procedures have been done. So how do you know what is a difficult hernia? So very broad category is a broad body habitus is morbidly obese patients, previous scar, and of course GA, the general anesthesia is usually done. So difficult hernias are large hernias, sliding hernias, irreducible hernias, obstructed or strangulated hernias, and recurrent inguinal hernias, a recurrence after a laparoscopic procedure which was done. Those are the difficult hernias. So of course we know the different types which are there in repairs of the hernias, and what our talk will cover will basically, what we are talking about is the laparoscopic repairs, that's the TEP and TAPP. The other methods are there for the ventral hernias and also for these procedures. Basically in TAPP, we assess the defect, recognize the important landmarks, divide the adhesions with the momentum and sac. Irreducible hernias, patients can be easily managed. So these are the advantages. Sliding hernias are recognized immediately. This is in relation, in comparison with the TEP repair. The control of bleeding is possible, and it is possible to combine this procedure with a diagnostic laparoscopy, and sometimes if it is an uncomplicated gallstone disease, though we do not advise it to combine with the other surgeries. So what is the advantage in a TEP? There is no violation of the peritoneal layer. Lower adhesive and bowel complications are there, and lower port side hernias are there. So what about extended TEP? It's a modification of the conventional TEP based on the anatomical fact that the inguinal preperitoneal space can be reached from almost anywhere. It provides us with a larger surgical field and more flexible distribution of ports. Now, in the annals of surgery, we had this paper on the critical view of the myobacterial orifice and the 9 steps to establish a critical view. So these are the very important steps which are required during the surgery. And of course, this paper by Cristiano Claus, which are 10 golden rules for the safe minimal invasive surgery using a new anatomical concepts as a guide. So we have different landmarks at the beginning of surgery. So incision of the peritoneum should be at least 4 centimeters above the deep inguinal ring. So here you have the deep inguinal ring. The flap should extend from the anterior superior iliac spine to the medial umbilical fold. So that is the rule 1 or the step 1. So what is the rule 2? Dissection should follow the peritoneal plane. I described the 3 zones. Now the fatty tissue present in the preperitoneal space should be kept in contact with the inguinal floor here and not with the peritoneum. The plane that exposes the muscle should be avoided in order to prevent damage of the inferior epigastric vessels at the zone 1 or 3. That is the zone 3. The zone 1. The nerves should not be systematically dissected or identified as it is recommended in open repair. So these are the things which you have to keep in mind. That is the zone 3 and this is zone 1. Now what is the rule 2? The rule 2 says that in a TAPP, we start the dissection either from zone 1 or zone 2, leaving zone 3 for the last. So the last area that is dissected is the central area which is dissected. Usually we tend to start from the medial area, which has the most constant anatomy. In TEP, the zone 2 is usually the first dissection, either with a balloon or by trocar, and then it is followed by zone 1 and 3 respectively. So dissection of the central zone is left for the last because it has the most varial anatomy. So here you can see how we have proceeded in this case. So what about the rule 3? The dissection should extend to at least the pubic symphysis. Here you have the pubic symphysis, 2 cm below the pubic symphysis at zone 2 in order to create a sufficient space to accommodate adequately sized mesh that overlaps the direct and the femoral triangles by at least 3 to 4 centimeters. And once we deflate the abdomen, the mesh should not fold upon itself, and that is why the dissection is pretty important. Here you have the pubic symphysis, and we have extended this dissection downwards. Here you can see the different vessels, and here the femoral canal and all the femoral hernia site is coming into view here on the topmost. Here you will have the obturator area. This is the area of the urinary bladder. So if present, the direct hernia sac is dissected, hernial contents are reduced, but the fascia transversus is dissected and kept distally. There is no consensus regarding suturing or plicating the transversus fascia. It may reduce the risk of seroma, but it also may be associated with potential nerve injury. So rule 4 is that the external iliac vein should always be visible. Thus, you can avoid a missed femoral hernia. So you have to dissect the external iliac vein completely. Here you can see this is completely dissected. This is basically the zone 3 we are talking about, and this vein has been completely dissected during this surgery. So rule 5 is parietalization of the elements of the cord. This is considered to be sufficient when the peritoneum is dissected inferiorly, at least up to the level where the vas difference has to cross the external iliac vein in zone 3, and the iliopsoas muscle is identified posteriorly in zone 1. So the psoas muscle will be here. Here you can see that we are dissecting the sac, and the parietalization of the sac is being done here. So we go on dissecting this sac until here you have the cord structures coming into view. Here we are gradually separating the different structures. The vessels are separated. Here you have the vas difference coming into view. So you have to go till this vas difference is turned medially and downwards inside. That is where you have to see. And the inferiorly, so that is where you have to completely parietalize this. The sac is being pulled out like that, and then you can persist with the dissection of the sac as you go along, so that the whole parietalization of the cord is. This is a very, very essential step during a TAPP repair, so that the folding of the mesh does not occur after you have closed up the peritoneum. Now, rule 6 is in large or inguinal scrotal hernias, it is recommended to transect the sac and abandon the distal sac. You don't have to go through the whole sac. Now, what does rule 7 say? That the deep inguinal ring should be explored during zone 3 dissection in the search of lipoma of the cord. So lipoma of the cord is dissected at this level. Here you can see the whole lipoma is, and every lipoma must be dissected and reduced from the inguinal canal. Otherwise, there'll always be swelling there. The patient will feel he's got a hernia. That is how we have dissected the whole cord. So at least a 12 by 15 centimeter mesh. The 12 is the craniocaudal distance. Here you have this defect where you should have a 3-4 centimeter overlap on all these sides, and it has to be covering the whole myopectineal orifice, that is including the indirect area, the direct area, the femoral area, and with the overlap of at least 3 to 4 centimeters. So for doing that, a 12 by 15 and sometimes we deploy a 13 by 15 mesh in patients, and as far as possible, the largest possible mesh size should be deployed. And it should be, because the area has been completely dissected and you have a sufficient area. Here you can see that the mesh can be placed comfortably. This cannot be done until and unless we have created an adequate peritoneal space for the mesh placement. Now, rule number 9 is mesh fixation. In TEP, it is not necessary. Even in TAPP, if you done an adequate dissection, not compulsory, but it is recommended in large hernias, especially in direct ones. Now, you have to avoid bony structures, attention to avoid the inferior gastric vessels, and no tacks below the iliopubic tract, and a counter pressure is essential during the fixation. Now, after deflation under direct visualization in TEP, prevent the pneumoperitoneum folding or rolling up at the bottom mesh. In TAPP, as the peritoneal flap is approximated, the mesh must not be elevated by the closed. So to summarize, laparoscopic inguinal hernia has less postoperative pain, fewer wound complications, faster return, improved cosmesis, lower incidence of groin pain. Bilateral hernias can be tackled, but it has a longer learning curve. So this is the basic talk on inguinal hernia. Now I'll just be going through a short video on a bariatric surgery procedure, which we have done. We just started off doing these procedures. So here we have, to summarize, is a patient, a 52-year-old female of weight of 140 kgs, height 156, so she had a BMI of 57 with obstructive sleep apnea requiring BiPAP. So she was a high-risk surgery with osteoarthritis and hypothyroidism. So we went ahead and planned a sleeve gastrectomy in this patient, looking at the very high risk and because she had a high BMI. So we just started this. First step is measuring. This is the pyloric junction, 5 centimeters from the pylorus, and we just marked, going through this anatomy of the stomach, and we started the dissection open. The first step is the opening up of the SS sac. The omentum has been separated. We are using a harmonic scalpel. Usually use a energy device to that. The very important thing is to dissect up to the left crus of the diaphragm, and the fundus has to be completely mobilized. Now we are using a bougie. This is a 32 French bougie we have put in it. The first stapler is fired 5 centimeters from the pylorus, and here we have used the Covidian gold stapler. And the next of the staplers we just along the bougie, and the orientation has to be kept properly so that you do not cross a narrowing. These are the purple staplers which have fired, and after every firing we're just checking to see the orientation of the sleeve. It has to be a straight sleeve. So that is the last part, which is the fundal area, and that is very, very important to see the fundal area properly in this patient, and that is the area with the leak occurs. Now what we have done in this patient is that for every point of junction of these staplers, we have put in PDS sutures. This is our technique where we have done that we have done at, first of all, at the fundal region where we have fired the first stapler. This is at the junction of the second on the second, third stapler. We've taken these PDS sutures at where we have a transition point from the different staplers from one to another. After the completion of this procedure, we have done a leak test using methylene blue. It was uneventful post-operative period. Gastrographin was done on post-op day 1. And then we have started. This is the post-operative 1 month picture of this patient. This patient lost around about 52 kgs in a period of 4 months. The patient was discharged without any complications on the 4th day. So thank you so much. And if there are any questions, I'll be glad to take them now.
So there is one question which I'll just forward.
Right. So the number of tackers, and please specify places to limit the number of tackers. So this is the question by Dr. Tejasvi Das. So the There, what we follow is a 3-point fixation. The first tack is on the Cooper's ligament, that is for just above the medial lower fixation, above the iliopubic tract. And then the second fixation we do is a lateral fixation, just on the lateral superior aspect, which is at the lateral most, at just at the round about the anterior superior iliac spine region where we had started the incision. That is the lateral edge of the lateral and superior edge of the mesh. And the third tag which we put is the medial and superior edge of the mesh. So these are what we follow as a practice. But what is the recommendation is that you should have at least the most important tag is at the Cooper's ligament so that the mesh does not get displaced. And the important thing to know is that the proper dissection has to be done so that after the proper dissection, there is no migration of the mesh, and there is a area which is adequate enough to entail the whole mesh inside, that is to incorporate the mesh, and the mesh shouldn't be folded. That is pretty important. So Dr. Prem has asked something regarding a fellowship program. He can contact us. We'll give you the details, Dr. Prem, and we'll just contact you. You can share your details with us, and we'll contact you regarding the same. Any other questions? I'll be happy to share. I'm happy to answer them. So I think we can.
So maybe we can wait for another 1 or 2 minutes and then move on to the next one.
No problem with that.
Yeah, sure.
So by that time, I'll just get the other speaker set up with his lecture. If there is any question, I'm here.
Sure, sir.
So now, Dr. Ajit Mishra, our GI surgeon, will be taking his talk on hepatobiliary pancreatic surgery after this. And within the next couple of minutes, if we have any questions regarding the short bariatric procedure and the inguinal hernia surgery, we'll be happy to answer them. We are here for you. Right. Sure. Questions के लिए I think there is no more question. Should we start?
Yes, sir. Let's proceed with the next topic, please.
Yeah. Thank you. Good afternoon, all of you. Myself, Dr. Ajit Mishra. I am a GI surgeon at Ramakrishna Care Hospital. And today I'm going to share some of the interesting cases in the hepatobiliary pancreatic surgery done at our center. And these are purely case-based discussions. And at the end, I would be happy to take any questions. So the first case was a 29-year female who presented to us with the abdominal pain, anorexia, and loss of weight. However, there was no anorexia and no jaundice. And on examination, there was a 10 into 10 centimeter palpable lump was there. So she came with the ultrasound, and that ultrasound showed that there is a gallbladder mass infiltrating the liver, but the mass was reaching up to the left lobe, and there was no ascites, no distant lesion. So based on this, we thought to get a CT scan, and this is a CT finding which shows liver. There is a minimal central IHBR dilatation and the presence of mass, which has completely replaced. You cannot see the separate gallbladder, and the mass is reaching up to the segment 3, and here it is reaching up to the segment 6. There was CBD is not completely and not separately visualized. In this picture, in the coronal section, you can see it is more likely in the inferior aspect of the liver. initially we thought it's adenocarcinoma. However, the absence of distant node with the large mass were negative against the adenocarcinoma. So we thought to get an FNA, and the FNA was suggestive of neuroendocrine tumor. Based on her age and the her CT scan finding, we thought we can go ahead with the resection and do a resection with unplug resection of the CBD, and intraoperatively this was the finding. This is the first thing that this is the normal liver, and you can see the projectile mass, which is mainly located in the inferior aspect. So we could get ahead with the resection, and it involved resection of the segment 3, segment 4B, 5, and the part of segment 6. And along with the extrahepatic duct was excised to remove the entire extent of the tumor, and the Roux-en-Y hepatic urinoscopy was done. This is the specimen which was there. The biopsy was showing the small cell variant of neuroendocrine tumor of the gallbladder. So this is quite rare pathology, because most of the time what we see is adenocarcinoma. This variant of neuroendocrine tumor is seen in 0.3% of the gallbladder cancers. However, the only option in these patients is complete surgical resection. None of the chemo and radiotherapy is effective, and even with the resection, the prognosis may be poor if the margins are positive. We will follow this patient and see how she behaves in the future. The next patient is a 35-year female who presented to us with the recurrent right upper quadrant pain, and there was sort of fever and chills, but no anorexia and weight loss, no jaundice. She was worked up later, which shows the LFT is showing high OTPT and along with the raised alkaline phosphatase. Based on this, we thought of CBD calculi, but the ultrasound shows the liver was having increased ecotexture, multiple cystic density lesion in the right lobe. CBD was normal, and gallbladder had multiple calculi. So there was some suspicion of cystic lesion. So we went ahead and did a CT scan. What the CT showed is that there is a multiple dilatation, and that was mainly involving the right lobe, and more so particularly in the right posterior lobes. And the dilatation was continuous with the biliary channels, and there also contained some of the sludge-like material. So then the extrahepatic duct was normal, and there was no abnormal and though as well seen in the liver. We went ahead and did an MR. MR shows the similar finding with the signal intense lesions in the right lobe, and there were continuity with the main biliary channels. So the diagnosis of Caroli's disease, and that too located in the right lobe, was made, and then the procedure was planned. Since the Caroli's disease involving only right lobe, the curative treatment is the right hepatectomy. So we made the diagnosis of Caroli's disease, and then she underwent a right hepatectomy. Intraoperatively, we could find there was some cirrhotic changes in the liver, but the liver function was good, and then we went ahead with the right hepatectomy. Again, this was in the biopsy itself that shows the features of history of Caroli's disease, with surrounding features shows some features of total hypertension. Patient did well in the postoperative period, and the incidence of Caroli's disease is 1 in million, and mostly it is recognized in the childhood, but it is less common, though present in the adults as well, and the treatment is always depending upon the distribution and the condition of the liver. The third patient is a case of intrahepatic cholangiocarcinoma. Most of the time we see hilar cholangio or distal cholangio, which is more common. This was a young male. He was 45-year male with abdominal pain, anorexia, and the weight loss. The workup shows there is a mass in segment 4, and then the CECT and the PET scan was done that shows localized disease in the segment 4. We went ahead and did a left hepatectomy with resection of the extrahepatic duct with a nodal clearance, and did a left hepatectomy with Roux-en-Y hepatic urinoscopy. There was 2 ducts involving the right side, so 2 separate hepatic urinoscopy was performed for this patient. And this was the specimen containing the mass in the segment entire left lobe. This is a case 4, which shows she was a 60. This is quite interesting case. This patient is a post-cholecystectomy female, who was 68 years of age, who presented to us with fever with chills and upper abdominal pain with anorexia and loss of weight. On examination, there was no palpable mass, no organomegaly, but the workup showed raised TLC and deranged LFTs. Uh, Based on this, the ultrasound shows liver with normal echodection, dilated IHBR in the left side, along with the mixed ecogenic mass in the left lobe with query cholangitic abscess. She was post-cholecystectomy, so gallbladder was not visualized and CBD was normal. Because she did not have gallbladder and presence of cholangitic abscess, we were suspicious of malignancy with the age also. And so we got the triple phase CT, which shows the left side you can see the ducts was dilated and there was some enhancing lesion in the left lateral lobe along with some capsular retraction. So there was two possibility at this moment. That one thing is that are we dealing with malignancy? Second thing was a suspicion of hepatolithiasis. So we went ahead and we did an MR. MR shows there was a signal intensity lesion in the intense lesion in the left lobe of the liver. Along with you can see the dilated channels with signal void structures. Again, the possibility of hepatolithiasis with query structure at the left hepatic duct, possibly benign or malignant, was considered. Because the lesion was situated predominantly in the left lobe, with the some sort of atrophy of the left lobe. If you can see, there is some atrophy of the left lateral lobe. So we thought to provide a curative option, and for these patients who's having intrahepatic stones, the percutaneous and endoscopic approach is not that successful. So, and the patient was, however, 68 years of age, but she was clinically fit, and so we went ahead and did a left hepatectomy. And you can see, and this was the first picture in which there is a mass lesion up, is appreciable, and then the entire left lobe was removed, and this was the cut section. This is the specimen. But when we opened the duct, it was filled with multiple stones. However, still at the medial end, there was a stricture, and this was a hard stricture, still suspicious of malignancy. But the final biopsy did not reveal any evidence of malignancy. It was a benign stricture with hepatolithiasis. So the interesting point of this patient that even the benign patients can present with the features of malignancy, but sometimes the treatment doesn't change. The last case number 5 is a 55-year female who presented to us with the just mild abdominal pain, who referred to us specifically for the lap cholecystectomy. However, the ultrasound shows a large polyp and filling the entire gallbladder. CBD was 1.5 centimeter. So based on this, we thought of, because of the polyp size was large and filling the entire gallbladder, we thought to get a CT scan to rule out the malignancy. And CT, what we found is, yes, the entire gallbladder was filled with a polypoidal lesion, but there was a dilated CBD, which was disproportionate dilatation. There was no IHBR dilatation. Along with that, what we found in the lower section, we found that there is a mass in the kidney itself also. So there was a possibility of coexistent RCC of the left kidney, and that is why we went ahead and we thought to get a PET CT. In the PET CT, what we found was there was a presence of GB mass, there was presence of left lobe mass. Along with that, there was a diffuse uptake in the thyroid lesion. There was more so in the left side, and so 3 lesions, and the gallbladder cancers going into the kidney or vice versa, kidney going into the gallbladder is very uncommon. And since there was no discrete lymph nodes, enlarged lymph nodes, so going isolated thyroid metastasis was also uncommon. So we thought to check with the final aspiration of the thyroid, and it's suggestive of atypical cells with Hurthal cell in the background. Hurthal cells are specific for the thyroid disease, so it was quite unlikely that these are metastatic to each other. Since the patient, no other feature was suggestive of metastasis and it was a resectable tumor, we went ahead and did a resection of all these things with the radical cholecystectomy with excision of the CBD, along with Roux-en-Y hepatogenostomy because of presence of colorectal cyst, the left radical nephrectomy, and the total thyroidectomy. The post-operative period was uneventful, and this is the intraoperative specimen of doing hepaticogenoscopy with a radical cholecystectomy. And all three specimens, they reveal the different biology. They are not correlated with each other. This was adenocarcinoma. This is typical of clear cell variant of the renal cell carcinoma, and thyroid was Hurther cell adenoma. So this is quite uncommon to get triple neoplastic disease in one patient, and that is why I thought to present here. This was a case of gallbladder mass with involvement of CVD, and he required a radical cholecystectomy with Roux-en-Y hepaticogenoscopy with excision of the CVD. Yeah, so this is my last pancreatic disease occasion. This is a patient who was young, 34-year male, presenting in the lump in the right upper quadrant along with the melena. He was referred to us after doing a diagnostic laparoscopy elsewhere, and in which they took the biopsy from the lesion situated at the hepatic flexure and duodenum, and the biopsy was inconclusive. Here, what we found is that there is a lesion in relation with the duodenum second part and with hepatic flexure, and then a US guided biopsy was done that shows a chest with the ISC features suggestive of all features suggestive of chest. Based on the size of lesion, he was started on neoadjuvant imatinib, and then after 6 months, when we repeated that the lesion was shrunken, still this is a lesion which is seen involving the second part of duodenum. Also, the hepatic flexure and the right colon was involved. There was suspicious involvement of the renal pelvis. Because already 6 months has been passed and now the lesion per se was looking resectable, we went ahead and we did a pancreatic duodenectomy with the right hemicolectomy. The kidney was free, so it did not require anything, but the pancreatic duodenectomy with right. In the post-operative period, all margins were negative, and he was again started for imatinib for the 3 years because of the size and the involvement of the chest. This was a complete complex resection in which even in the chest patient. So this was quite interesting. So thank you. I'm ready to take any questions. Question कहाँ दिख रहा है? कहाँ? नहीं वो लोग करेंगे तो आएगा, पॉपअप आएगा. Chat. कौन सा कर दिया उन्होंने? Hello.
Yes, so there was a question on the previous session of hernia.
Yeah.
And there's one more which I'm just sending you on chat. 1 minute.
उसमें एक्सेस लिखना.
Hello. Yeah, am I?
Yes, you are, sir. I've just shared one question on chat. If you
Yeah. The question is imatinib specific protocol for duodenal cyst. So there is no separate protocol for duodenal cyst. Any cyst, if you think that it requires, it is either unresectable or it requires multi-organ resection, which may not give that much of benefit. If you plan, so the imatinib can be started as a neoadjuvant or the adjuvant therapy. In the adjuvant, if the size of the lesion is more than 3 centimeter or there is a marker like mitotic index, Then high-risk patients requires imatinib for minimum of 3 years. In the neoadjuvant setting, when the conditions are met, then you start imatinib and see the response after 6 months, say after 3 months or 6 months, and the response is adequate, and you can go ahead with the surgery. So it all depends upon the location, the organ, and the extent of resection. Thank you. So I think if there is more question, I will be ready to answer. In meanwhile, our next speaker, Dr. Vikram Sharma, will take on laparoscopic GI surgery. Thank you.
So I am Dr. Vikram Sharma. My topic is laparoscopic GI surgery, and I will share few common laparoscopic GI surgery videos. To start with, a little about history line of laparoscopy. In 1983, Sam performed first laparoscopic appendicectomy. In 1985, Muhe performed first laparoscopic cholecystectomy, and soon lap chole became the gold standard for cholelithiasis. With the advancement in laparoscopic surgery, now almost all GI surgeries can be done laparoscopically. So these are the advantages of laparoscopy. We all know the role of laparoscopy in GI surgery includes diagnostic laparoscopy in patients where diagnosis is uncertain even after all investigations and radiological imaging. It is also useful in cases like abdominal COX or CA peritoni, where with diagnostic laparoscopy we can take a biopsy from the peritoneum and lymph nodes sampling can be done. Staging laparoscopy should be done in all GI malignancies. Then there is role in palliation like laparoscopic feeding jejunostomy, gastrojejunostomy, or lap-assisted ileostomy or colostomy can be made in advanced malignancies. Curative resections for operable GI cancers, and laparoscopy is also useful in post-operative problems like adhesive obstructions, incisional hernia, and leaks. So now discussing individual organs, common laparoscopic esophageal surgeries are esophagectomy, Haller's cardiomyotomy, fundoplication, and paraesophageal hernia repair. So this is the first case of laparoscopic Haller's cardiomyotomy for achalasia cardia. Sorry. Left lobe of liver is retracted. Hiatal dissection is done. The esophagus is mobilized. This is right crus. Esophagus is separated from the right crus. Then gradually the esophagus is mobilized from all direction. This is the right crus. Circumferential esophageal mobilization is done. Then myotomy is done. The muscle layer of esophagus are split. The outer layer, this is the outer layer, longitudinal muscle layers. Beneath this will be the circular muscle layer. Care must be taken to use as minimum as possible of energy sources. The muscles are split. This is the circular muscle layer. And below this, we can see the mucosa of esophagus is bulging. The length of myotomy towards esophagus should be at least 5 to 6 centimeter. And this is myotomy towards the stomach. Then the fundus is mobilized by dividing the short gastric vessels near fundus. This is intra-op upper GI endoscopy was done to check the completeness of procedure. Here we can see the endoscope is passing easily through GE junction. There is no obstruction. Then anterior door fundoplication is done. This is done because after cardiomyotomy, 60% of patients develop gastroesophageal reflux. So, and also if there is any small iatrogenic esophageal perforation, then this fundus will cover that perforation and will help in healing the perforation. So this was the first case. Next, this is a case of large paraesophageal hernia. Left lobe of liver is retracted with Nathanson's retractor. This is a large hiatus hernia, type 3 paraesophageal hernia with both G junction and fundus lying in the hernia. Slowly, the contents were reduced. Short gastric vessels near fundus were divided. Then paratylation of right crust was done. Along with this, the hernial sac is reduced from the hiatus. Lesser momentum was dissected and free. Then esophagus is mobilized. All periesophageal thin attachments were divided. This is the vagus nerve. It should be identified and preserved. Further, the esophagus is mobilized. At least 5 to 6 centimeters of esophagus should be mobilized so that G junction can be brought into abdomen. An umbilical tape is passed around G junction for traction. This is the around 5 centimeter length of esophagus mobilized. Then both the crura were approximated with Athibond suture. 3 to 4 interrupted sutures were taken to approximate the crura. But as this was a very large hiatus hernia and the crura were very thin, so to reinforce this closure, we used a composite mesh. The mesh was fixed over the crural closure. It was fixed to both the crura. There is shoe-shine maneuver to check whether the fundus is freely mobile or not. Then over the lower 2 to 3 centimeter of esophagus, 360-degree Nielsen's fundoplication was done. So this completes the Nielsen fundoplication. Then coming to laparoscopic gastric surgery, it includes bariatric surgery, various types of gastrectomies for malignancy, surgery for perforated ulcers, gastrostomy, and GJ for gastric outlet obstruction. Laparoscopic approach for bariatric surgery is the gold standard. These are common types of bariatric surgery done by laparoscopy, that is gastric bypass, sleeve gastrectomy as shown by Dr. Siddharth Tamaskar, adjustable gastric banding, and duodenal switch. For malignancies, comparing laparoscopic and open approach, there is no difference in tumor staging, in resection margins, in lymph node retrieval, and there is no difference in survival between two groups. This was a paper published in World Journal of Gastroenterology in 2017, and it concluded there is no difference. There is laparoscopic and conventional D2 gastrectomy have comparable outcomes. So laparoscopic D2 gastrectomy includes gastrectomy along with removal of perigastric lymph nodes, that is from station 1 to station 6, and then the lymph node along the named surrounding vessels. Station C, this is station 6 along left gastric artery. This is station 8 around common hepatic. Around celiac, it is station 9. Station 11 is along the splenic vessels and splenic, and this is the station 12 lymph nodes. This is the patient position for laparoscopic D2 gastrectomy. This is the port position. This is the supraumbilical camera port. These two are working ports, and these two are for assistance. So this is a small video of laparoscopic D2 gastrectomy. There is a growth in the antrum. So first step is division omentectomy. Omentum is separated from the transverse colon and separated from the transverse mesocolon. Then the right gastroepiploic vessel is identified and circled, and it was ligated and cut. This is the gastroduodenal artery from which right gastroepiploic is arising. Then the first part of duodenum is mobilized, and it was transected with linear cutting stapler. The line of transection is around 2 cm distal to pylorus. Then the right gastric artery is identified. It was ligated and cut. This is the lymph node dissection around common hepatic artery, that is station 8. Lesser omentum with station 3 lymph nodes were dissected. This is proximal splenic artery node, station 11P. Then the left gastric artery is identified. It was dissected and ligated and cut. And along with this, lymph node around was dissected. This is station 7. Then this is the line of transection of stomach. It should be at least 2 cm below the G junction in lesser curvature side, and at least 2 to 3 short gastric vessels were left in greater curvature side. And then Ru and Y gastrojejunostomy was done. We usually pass NJ tube through gastrojejunostomy so that feeding can be started early. Next is very common surgery, laparoscopic perforation closure. This is a video of gastric perforation. All the collection were sucked. Adhesivolysis was done. Here we can see the perforation. So this perforation was closed with PDS 20. 2 interrupted sutures were taken and the perforation was closed. And above this, omental patch was fixed. Lavage was done and drains were kept in subhepatic space and pelvis. This is our experience of laparoscopic perforation closure. Total 588 patients were operated in last 15 years. All patients underwent perforation closure with omentopaxy. Median operating time was 54 minutes. 15 cases were converted to open surgery. Almost all of the patients were discharged between 5th to 7th post-op days, and there was total 12 mortalities. Then last, coming to laparoscopic colorectal surgeries, it includes resection of malignant tumors, that is right hemicolectomy, left hemicolectomy, sigmoidectomy, low anterior resection and APR, colectomy for ulcerative colitis, surgery for colonic diverticula, and rectopexy for rectal prolapse. So comparing open and laparoscopic surgery for colonic malignancy, overall and disease-free survival rates are same for both. There is no difference in carcinoma recurrences. And with laparoscopy, early recovery of bowel function and shorter stays noted. With the advancement in technique and anesthesia, now advanced age, obesity, bulky tumor of prior abdominal surgeries are not absolute contraindication for lap surgery. This is a video of right hemicolectomy. This is medial to lateral approach. The cecum is retracted towards the parietal wall in right iliac fossa. The ileocolic vessels were identified. This one is ileocolic artery, and just below it is ileocolic vein. So these were carefully dissected, and they were ligated and cut. This is ileocolic vein. The ileocolic vein was cut. This is ileocolic artery. Then the mesocolon is lifted from the retroperitoneal structures. Here we can see the duodenum. The mesocolon is lifted from the duodenum, and this duodenum is pushed downwards, and the mesocolon is pushed upwards. And this dissection continues till we see the inferior surface of the right lobe of liver. This is the inferior surface of right lobe of the liver. After this, further mesocolon dissection is done. This is the middle colic artery. We have to dissect the right branch of the middle colic artery, and it has to be ligated and cut. This is right branch of middle colic artery, and this is the right colic vein. Both were dissected, ligated, and cut. Then the lateral peritoneal attachments were divided. The hepatic flexor of colon is mobilized. There is the terminal ileum lifted from the retroperitoneum. Care should be taken to not to injure the ureter, right side ureter. This is hepatic flexor mobilization. And in last part, the omentum is divided from the transverse colon. And then with a small incision, the specimen is taken out and iliotransverse anastomosis is done. So this is the last case, laparoscopic low anterior resection for CA rectosigmoid. The sigmoid is lifted towards parietal wall in the left iliac fossa. The peritoneum over mesocolon is dissected. This is IMA, inferior mesenteric artery. It is identified and circled. This is inferior mesenteric vein. The inferior mesenteric artery is ligated just near its origin. That is high ligation of inferior mesenteric artery. This is the left ureter. It should be identified and pushed downward so that it doesn't get injured. This is IMV, inferior mesenteric vein. This is clipped near DJ flexor, near the inferior border of pancreas. Then the left side of mesocolon is lifted from the retroperitoneum. This is pancreas. The mesocolon is lifted from it. This is the ureter, the left side ureter. This is left kidney. Then the lateral peritoneal attachment of left side colon were divided. Splenic flexor was mobilized. Then we did the pelvic dissection. In pelvis, the posterior dissection is done in the holy plane between the presacral fossa and the fossa covering the mesorectum, that is fossa propria. This is left side dissection of the mesorectum. The dissection is further carried down towards lower side. The lower end of the rectum is cut with margin of around 5 centimeter. This is the cut stump. Then with a small incision, the specimen was taken out. Anvil was fitted in the descending colon, and colorectal anastomosis was done with circular stapler. So these were few common laparoscopic GI surgeries videos. And to conclude, nowadays almost all GI surgeries, including bariatric surgery and surgery for malignancy, are feasible and safe by laparoscopy in a well-structured minimal access and GI surgery department. Thank you. Any questions?
So viewers, we are done with all the topics for today. If you have any questions, please post them now. Sir, in the meantime, there were a few questions on the previous session in case if you can take it or if they are around.
Okay, I will call them.
Sure.
Just 1 minute. So there was a question for Tamaskar sir. For mesh repair, suturing is safe or not? Yes, suturing is safe and it is better than tax, but it requires a lot of time and it has a longer learning curve. But if you are comfortable in suturing, then suturing is always better than tax.
Hello. Hello. Yeah, there was a question from Dr. Rishi Agrawal. Was FNAC tried in patient with hepatolithiasis? No, FNA was not tried because there was two possibilities to begin with. One was hepatolithiasis with or without malignancy, and when the lesion is resectable, and even for the hepatolithiasis, the treatment would have been the same. So FNAC was not tried.
Thank you for answering that, sir. I think we'll just wait for another 1 minute and to see if there are any questions, else we conclude this session.
Sure.
Okay, so I think if there are no more questions, we end this session here, viewers. Thank you for joining us live. And we would like to thank Metronics and the team of Ramakrishna Care Hospital, all the senior faculty there, Dr. Siddharth Tamaskar sir, Dr. Ajit Mishra sir, Dr. Vikram Sharma sir, and Dr. Dave sir. Thank you so much for your time and for this enlightening session. Thank you, sir.
Thank you very much.